Okay, so for scenario 1, question 2, we are going to check for a lateral ankle sprain or fracture. And first, you can start with observation. You can see that there's no swelling, ekmosis, or gross deformity. Then we are going to palpate the ATF, which is about right here, the CF, and then the PTF, which is about right here, and as well as the cuboid. So let's find the base of the fifth. So it's about right here. And for range of motion, you would use a goniometer, but I currently do not have one of those with me. So if I did, I would place the stationary arm parallel to the fibular and place the fulcrum at the lateral malleolus. Then you could have your patient plantar flex and dorsiflex, moving the movement arm with the foot, measuring the foot when the foot is fully either plantar or dorsiflexed, and making sure the arm is parallel with the fifth metatarsal. So using the Taylor tilt test for the integrity of the ATF, CF, and PTF, we're going to start by stabilizing proximally and then grabbing the calcaneus and distracting slightly. If the patient is fully plantar flexed, then we will cause a slight tilt in the inversion, which will stress the ATF right here. And then we can move to a neutral, plantar flexion and dorsiflexion, and then invert. Neutral, invert. That would cause stress right here in the CF. And then we can have them dorsiflex and invert, and this will cause stress in your PTF. Okay, so now we're going to do the Kliger's test, or the ER test. We will be testing two things. If the patient is in plantar flexion and I stabilize proximally and grasp the distal part of the foot, everting with plantar flexion, this will cause it to put stress on the deltoid ligament, which will have localized pain around here. If we dorsiflex and evert, then we will put stress between the tibia and the fibula, which will give us a positive sign that indicates that the patient may have a high ankle sprain. Now we are going to perform the squeeze test. So we're going to put our hands behind the leg, putting one hand on the fibular head, just this hand, and then this hand will go on the medial portion of the tibia, and we will squeeze, working our way down until we reach the malleoli, asking the patient when they feel pain. The higher the pain is, the worse the injury.